you want to have them, first of all, into full flexion this time. So I'm gonna have you do this in a minute, but I'll show you the position. This time, because how did we normally do that, and it doesn't work as well, is if we had them supine, correct, like a hamstring stretch position. That's not the position you're gonna have them in. The patient's flat supine. No, you're just in the middle.
Oh.
Middle, staying in the middle. And then you have them bring their knees fully toward their chest. This way. So they're at this here, and then you hold this position for the 60 to 90 seconds. So I'm going to have you up there, and then we'll, Gracie, you can get
Okay.
Okay, so then you're gonna do just a static stretch first for the 60 to 90 seconds, and then bring her back down. And then what's going to happen to the uninvolved leg? Because where was the uninvolved leg before for the other one that we just did?
With the home exercise, he was holding it.
Right, and well, and then they were still, where were they when you did that, when you were doing the, well, when you did the hold relax,
Straight.
they were into, it was here. Right, remember, we still had, let's do that one again. We're, just to remember, if it was posterior, she would have been, it was off the leg, this, and then where was this leg?
She was holding it.
Holding it, It's still in this position. The patient was still here.
Yeah.
Okay, here. And belted, remember I said you'd have to belt them down. So if, for this one, it's going to be, she's still gonna have the leg off, but which leg's going to be off this time? On that side. So we're still gonna have that leg off. And now this one comes to her chest, and then Gracie's gonna get up there, you can get on the table so you have more leverage. And then Gracie takes over, then the patient can just relax. And then you hold that in. So you hold both of them for the 60 to 90 seconds, then you get her in position, and then she's just going to push into Gracie's hand into extension. So push, 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 push. For 10 seconds, relax, breathe in, breathe out. And push.
Not strong enough for
Push,
this.
push. And we're still doing that, relax, breathe in, breathe out. And we're still doing that same thing for those 5 to 6 repetitions until you get to, until you do the, how many do you do? So you get to the 6th one, then you hold that for the 60 to 90 seconds, and it's still, then they do back on the table. No. And then what comes after they've done, then you're just doing.
Oh. Golly, Sean.
And then relax. So you're doing the 10, the break, we call that the break maneuver, listening for that pop. If you do hear the pop, then you stop and you know that you've realigned the anomalant.
So you're doing the exact same thing, you're just doing the exact same
Extension.
stretch on the
The opposite, but you're doing, but think about it more that you're just doing the opposite contraction. For a posterior anomalant rotation, they're contracting their hip flexors. For an anterior anomalant rotation, they're contracting the hip extensors. Now there is, for this one, you can do a counter resistance, and I want you to be able to do this one if you are doing this on the practical. So a counter resistance means that from this position, I'm gonna show you you can do it. You're basically having them at here, and then you have the patient counter resisting. So she's gonna push up into flexion on the left and into extension on the right. So push, 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 and relax. And then again, push, 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 and relax. Again, push, 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 and relax. And then you switch and do it the other way. Push, 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 relax. And you're still doing it those 5 to 6 reps each time you do that. And then you're bringing them to that new end range, except you're doing the counter resistance. Okay,
When are we doing the counter resistance one?
and then, is it different this way, do you think, the counter resistance? When you do the break, what do? Push, 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 this way for, how many seconds? 10 seconds. Then they go this way. Push, 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 push for 10 seconds. Then you go back out, do it this way until you hear that, feel that pop. Or if you don't, then you do it 3 times each way. 3, 1, 2, 3.
When are we doing that one?
What do you think?
So both out of them?
Pulse, if they have bilateral symptoms, yes. And if you can't really tell what direction it's out. So there are a lot of times when clinicians are like, I don't really I can't get a good test. The long sit's not telling me what direction it's out in. And what might that be? If when you do the long sit test and you're getting those weird results, you'll see clinicians do the counter rotation if it is from short to neutral, neutral to short, but not truly going from long to short to be able to give you a definitive direction of the rotation. Okay. So then how would we have them doing this at home? Let's go back, not the counter rotation, but if we did say if it's an anterior anominate rotation over here, their home program would be what? They'd still be with the leg
Out on the side.
over the side,
Hold that knee and push.
and they can do it all, can't they? This one's a great one. When I have patients with an anterior rotation, it's easy for them to do their home exercise program. They're just doing the stretch for the 60 to 90 seconds, and then what would you tell her to do?
Bridge.
Well, first, she would have bridged first, and then you just have her to do
Pushing
this,
and
pushing, but still that your leg is over here, over the side, she'll be over the side. And then she just pushes into her own hand, push, 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 relax, breathe in, breathe out, and you're gonna do that for the 5 to 6 reps. And at the 6th rep, she's gonna hold that for the 60 to 90 seconds, and then after she's finished with that, then that's the adduction.
Would you ever recommend like someone else, like if there's a family member, to perform that with them, to resist them?
Yeah, sometimes, it just again depends on if I feel like that they can do this, yeah. But most of the time I do not, because I feel I'm not comfortable with them doing it. So that's the home exercise correction of the rotation anterior. Okay, just don't forget that the counter rotation is going to be, you'll see that quite a bit when, again, clinicians are not sure exactly what's going on that particular side, so they'll do the counter rotation. And I've even at home, if I'm not for certain exactly what way that it's going out, I will, I think it's like a posterior rotation, I'll teach them at home to do the posterior rotation, but I'll have them do the counter rotation break. And that's okay to do too if you're not completely sure, so you might see that happening too. All right, thanks, guys. Okay, and then the leg length measurement. So the leg length measurement, you guys have to take measure, so who didn't come up over here? I had it, Maddie. Jenna, come on up.
You have what?
We haven't been up here, just come on up and grab the tape measure on your way up. Okay, so now you lie down. Okay, so if this is the leg length measurement. I thought it was in your book, but I couldn't find this. So this is number 7, leg length. So when you're just measuring a patient's leg length, it's best if their shoes are off so you can see their malleoli better.
On the shoes.
Then you're gonna have them to bridge first. And always before you measure, you do the same thing that you did with the long sit test first, Jenna. So you're gonna palpate her ASIS and crest. So up here, just palpate, get an idea of which one do we feel like maybe when we measure it, which one's gonna be longer or shorter. And we're still referencing what side?
The affected symptomatic.
The symptomatic affected side. So on Maddie, we'll say that, let's say that her right leg is hurting her. So what was happening over there? Was it looking? Okay, let's see. Correct, yes. It's slightly lower over here on the right. And then she would go down to, and after she bridged though, did you do the distract, the three, or
That's what I was
flax or
gonna-
anything?
Yeah.
Okay, so just gently do the three. And it's gentle, it's just like a grade line. And then she would have done that prior to doing this. So we already know that was a little bit lower. And then when she comes down here and looks at the medial malleoli after she cups her hands, you're gonna. And then go right above it, just go right above the each malleoli. And then look at your finger, you're gonna kinda go above and see. And then that should look slightly lower as well, because if this is lower, her medial malleolus is lower.
And this one? Or these ones?
These, yeah, right here, you're looking at the medial malleoli. And see hers is just slight, very, very slightly lower. And I'm at the top of her malleolus. And this one's looking a little lower. So with that being said, before we measure her, we would hypothesize that which one's longer. The right. It's gonna be longer. But we don't know, we're gonna measure and see. Okay, so when we measure, we're going to measure from the ASIS to the medial malleolus, the inferior pole of the medial malleolus.
10 centimeters on the same.
Yes. And then this time you go to the bottom of the malleoli.
I'll hold it up. Thanks, pal.
No, it's right down here, the inferior part of the, well, that's it.
I cut the patella grind, took
So is that the PD? Yeah. 99 centimeters. And then, this is a common mistake, people will do this, and then they'll just move over the tape. You have to retract your tape measure, and then go to the other side. And then you're going from the ASIS to the bottom of her medial malleolus.
That one's 101.
So, that wasn't what we thought, and that's okay. So we have 99 and 101, so that would be a positive test because it's greater than a centimeter difference. So then you're gonna measure from her belly button, so where's your belly button, Maddie?
There.
So we're gonna do the same thing.
On the side or the side?
Yeah, we'll start on the left.
Wait, 110?
Yeah, 110. Retract the tape measure. And try not to, don't hold the tape, just like let it go. So that was negative. So it has to be greater than a centimeter difference to be a positive test. So Maddie's was positive for a structural leg length discrepancy. I'm not sure that's right. We'll remeasure that in a minute. I'm not sure. But if it's from the ASIS, if that measurement from the ASIS to the medial malleolus is positive, they have a structural leg length deficiency. And if it is the one from the belly button is positive at a greater than a centimeter, it's a functional leg length discrepancy. So if someone has a structural leg length discrepancy, what might their problem be? Because structural means the bones are actually longer or shorter. That's why I'm not for sure that that is correct when we do it now when we are practicing. So structural leg length discrepancies come from the bone wearing away, so it's actually gonna be, you're actually gonna have a shorter bone on one side. And so what causes that? Severe OA of the hip or the knee, severe deformity at the knee, where you've got a lot of wearing down of the bone will cause a structural deformity. Some pediatric or adolescents patients who have had hip dysplasia, where that hip was very unstable and grinding away at bone, they can have a structural leg length discrepancy. So those are the common diagnoses with pure structural. An x-ray would show that leg, the bone is actually different lengths. And structural leg length discrepancies are muscle imbalance, where there is something going on biomechanically that's making it appear to be one going to be shorter or longer than the other. So it's not a true, that's why I think in your book or a lot of textbooks will reference it as true versus an apparent leg length discrepancy. A structural, which is a true, or functional, which is that apparent leg length discrepancy. If you have a functional leg length discrepancy, then that can be associated with like what diagnoses, what types of patients will have these functional leg length discrepancies. Herniated disc with those lateral shifts. Yeah.
Muscle imbalances.
Right, any type of muscle imbalance, but a lot of times those muscle imbalances come with like patellar trachy. So some patients who have chondromalacia and patellar tracking can have issues with a leg length discrepancy, functional leg length discrepancy. Scoliosis is a big one. You can have a functional leg length discrepancy because of that curvature in the spine. So any type of tracking issues can cause a
Would
functional
that be
leg
a
length.
non-functional, or? I thought there was two types of scoliosis, structural and then non-structural.
Yeah.
So would structural be,
It's still functional because it's the spine. It's the curve of the spine is actually fixed, but it doesn't do anything to the actual length of the leg bones.
Okay.
So this would still be considered, that's a good question, this would still be considered with scoliosis a functional leg length discrepancy.
So if did you mean like non,
yeah, and like non-structural slash functional and structural scoliosis?
so they would probably both cause.
Function,
Yeah, functional.
That's
right, even a fixed curve versus a functional curve still ends up with a functional leg length discrepancy. So if this test is positive, then now you know a lot of other tests that may be positive as well. So if this test is positive, what else could be? Oh, and I think, Tessa, innominate rotation causes what type of, not structural, but
Functional.
functional, because the rotating of the innominate doesn't make these bones any shorter.
That makes
Because to
sense.
truly have a structural leg length discrepancy, these bones have to be actually shorter.
Okay.
And arthritis causes that because it breaks this down, breaks the bone down, and this leg gets shorter. Or it breaks the bone down at the knee and the leg then gets shorter. So a nominate rotation, so if this test is positive for a functional leg length discrepancy, then they may have a positive long sit test. If this test is positive for a structural leg length discrepancy, they could also have a positive Faber's test with pain in the groin. Because the positive Faber's test in the groin indicates hip joint OA. And people who have severe hip joint OA can end up having these structural leg length discrepancies because the bone is worn away so much that it's actually become shorter. Does that make sense? Everybody have any questions about the leg length test? What about positives and negatives about this test?
I'd say you get a lot of,
Well, let's talk positive. Do you think it's reliable? Do you think it's valid? It is, because you're really, if you have them neutralize the pelvis, then that's gonna be, that is a reliable, if it's done correctly, it's reliable and valid for the length of the legs. What were you going to say, Jenna? Because I think you were going the right way. The disadvantage is that, again, with the knowing, being exactly on the landmark, if you're not, because I think the ASIS is hard, you know, you could be off a little bit. So again, that can cause some false positives if you're not directly hitting those landmarks exactly right. This test has good intra-rater reliability, but the inter-rater reliability is not as good.
I was gonna say, I feel like it would be valid though, because I mean, like whether it's structural or functional, it could be, I don't know.
Well, structural, you know that you're measuring from the different landmarks. It's functional if you, because you're measuring from the belly button and not the
Okay, yeah,
sides.
forgot there was two parts of it. Okay.
Yeah, it's gonna show you, it's good at, you know, telling if it's structured. And you know why this one's structural, because you're on the bone. Functional, you're on the belly button. Because think of, here's your belly button, and if I have bad muscle imbalance, then my belly button moves.
That makes sense.
Right, any questions about this test here? The last test that we're gonna go over is the Paduli sign. And we talked about, this one briefly when we talked about SI, but the Paduli sign is that you're gonna have the patient to bridge, you can just say this one, you don't have to say it, I'll just put this one on, okay. So you're gonna have the patient to bridge 3 times. And then you're gonna have them to still straighten their legs and do the distraction. In the Paduli's test, you're gonna have the patient standing for their first, so they're actually gonna stand up for the test. So stand and face away from you. Stand and face the back of the room, not behind you.
Okay.
And then you're gonna palpate the patient's PSIS. And once you find the PSIS, you're gonna see if they're symmetrical, just like we've been doing with the ASIS. And you're going to reference that again by the symptomatic side. And for this test to be positive, the symptomatic side PSIS should be lower, because when they bend forward, so just do a forward flex, like we're gonna reach and touch your toes. And then you're looking to see what happens to the one that was
Going all
lower.
the way down.
Yeah, with you, they go all the way down with they have to keep their knees straight. That's a bad part of this test. Now come back up. And a positive test is if the lower PSIS became higher upon forward flexion. Do that again. So the lower has to become higher. And then come on back up, and that's positive for IS dysfunction. And then you have the patient to do the same thing in sitting, so you have them sitting in a chair or a stool. And then you're still finding their ESIS like you did before. And then have them do that seated forward flexion with hands between knees. And then come on back. And for the test to be positive again, the symptomatic side has to go from low to high. So if it's her left, it has to be sitting at rest down here, and then when she forward bends, it has to go higher. So it goes from low to high. And Fredoli's test in sitting is a positive for sacroiliac or SI. So when she was standing, it was IS, and sitting, if it's positive, it's going to be SI issues. So when you do the Paduli's test in standing, if this test is positive, what other tests should also be positive? Because this is positive for what?
IS. So the figure 4 one.
No, that was not IS, that was
That was
SI.
SI.
Which it'll be for here, but that's so you can say it when we
For
sit down, when
sitting.
we sit her down. So when she's doing this test in standing, if it's positive in standing for IS, and come on back up. What other test that we just did,
Long sitting?
the long sit,
But just posterior, right? Or would it be?
but you don't know.
Okay.
It's just an anomaly that rotates, it's saying it's an IS problem, so she could possibly have a anomaly rotation. So then in sitting, what other tests could be positive?
Figure 4.
The figure 4, the Fabers. But this time, the Fabers with pain where?
In the back.
In the back. If the Fabers test has pain in the front, what other tests, when you're reading the evaluation, what other tests would be positive with that we just said? If they hurt in the front, we said they could also have a positive
Could be leg length.
leg length, structural. And here, this is, if SI, then what other tests would be positive here? If this is positive in sitting, then it's the Fabers, and what other tests that we did Monday? Or SI. Well, yeah, we did this one, I think, today, but before that, the straight leg raise, the well and the bilateral. Less than or greater than 70. Less than 70. So the wells and the bilateral, if their pain increased, that radicular pain increased before 70, that's indicative of SI. This one is also indicative of SI issues. And when you think about the sacrum, if it's moving like that in sitting, that is more indicative of a torsion than in standing. When it's moving, that's more indicative of those innominate bones are rotated in one direction or the other. So this test, the Paduli's test, the advantage of it is that it looks at both IS and SI problems. The disadvantage of the test is if they have hamstring tightness, it's inaccurate. Because you saw if you can't do a full bend to the floor, to your toes without knee bend, then you can't do the test. It's inaccurate. So if they have tight hamstring, this is an inaccurate test. And if you went ahead and did it and they had tight hamstrings, it's always going to show negative because you're not getting enough movement. So it would be a false negative.
Can you repeat the advantage again, real quick?
It just tests both the SI for sacroiliac and iliosacral problems. Thanks, Matt. Okay, that completes our, testing for the hip. I looked at our timeline.